And we're all familiar with the concept that Dr. Braunwald introduced in the late 60s. It takes time for aortic stenosis to mature and degenerate, to become severe. And once it's severe, it also takes time before symptoms occur. But once symptoms are there, then there is an urgency to treat these patients. And the guidelines are very clear about that. So let's briefly touch upon disease progression. Once you have a patient with moderate to severe aortic stenosis, there is a progression rate per year that can be anticipated as follows. You can monitor the maximum velocities, the mean gradient, or the valve area. And if I just focus on the valve area, you can expect about a decrease in valve area of 0.1 centimeter square. So that is just a ballpark estimate, but it might become interesting when we are discussing the TAVR UNLOAD trial later on. That said, the Ejection score cannot replace dobutamine stress echo. And this is a recent publication that we did together with Steve Little. We identified 214 patients with a valve area of less than 1 centimeter square, but a mean gradient less than 40 and maximum. We did look into the literature, and we were also part of this comparative study. Again, we did a propensity scoring, a propensity matched analysis, where we looked at the Atlas TAVI registry. This is a registry on patients with low flow, low gradient AS. Patients had dobutamine stress echo, and so you had a subset of patients with pseudo-severe, therefore moderate aortic stenosis, who received a TAVR valve. Now we one-to-one matched them to patients with moderate aortic stenosis in our practices. Turns out that the patients who were treated by TAVR, those patients had the best survival and had fewer heart failure hospitalizations. So this again was an indirect link to potential benefits of TAVI or TAVR for moderate aortic stenosis. The TAVR UNLOAD is a randomized controlled study looking for patients with symptomatic heart failure, so they had to be in New York Heart Class 2 or higher, and they had to have guideline-directed medical therapy in combination with moderate aortic stenosis. The patients would be randomized to transfemoral TAVR with a balloon expandable valve or clinical surveillance. Clinical surveillance with the plan to treat the aortic valve once it was documented that moderate aortic stenosis had transgressed to severe aortic stenosis. What happened to the patients in the clinical surveillance arm? And obviously we would be interested in the progression to severe aortic stenosis because those patients were not being treated for their aortic stenosis at that point. Turns out that 39% of the patients in the clinical surveillance arm progressed from moderate to severe aortic stenosis, and almost 20%, 16 patients, the first year. And then in the subsequent years, more patients were progressing from moderate to severe aortic stenosis. And the point is that those patients all of a sudden had a class 1 indication for aortic valve replacement. So they all were treated with a TAVR. Half of those patients had an adjudicated heart failure event. If you look at all the patients in the control arm and the clinical surveillance arm who received a TAVR valve, then you end up with 43% of the patients. So all the patients who progressed to severe, but also a couple of patients who had proven and confirmed moderate aortic stenosis went on to get a TAVR procedure because they had recurrent heart failure events. This is a competing risk analysis in the clinical surveillance arm. So on the left-hand side, you see the proportion of patients who received a TAVR, and you see over time, more and more patients were being treated with a TAVR because their moderate aortic stenosis progressed to severe. On the right-hand side, you see the proportion of patients who died without receiving a TAVR. And also there, over time, you see the number is growing. So at 3 years, all the patients in the clinical surveillance arm either had a TAVR or had died. So there were no more patients who were not treated and were still alive in the clinical surveillance arm. And this is quite a remarkable observation. Again, we see here that TAVI patients did better than the clinical surveillance patients. This is basically an echo of all the data that we saw running into the TAVR UNLOAD, the retrospective analyses, but there is selection bias, but the patients who received TAVR seem to do better than the patients in the clinical surveillance arm. What were the predictors of survival in our registry? Well, TAVI was probably a strong predictor for survival. So I don't believe that that TAVR Unload is the end of the story. The story is only beginning, obviously, and I do feel that we will need more randomized studies, and I'm very much looking forward to the progress and TAVR Expand 2 results.